Good afternoon, everyone, and welcome to the next installment of our Pulmonary Fibrosis Foundation Disease Education webinar series. I am Amy Hajari-Case, the Chief Medical Officer at the PFF, and I'm so glad that all of you have joined us today. We have a really hot topic and a lot of interest in this area, mold-related hypersensitivity pneumonitis. And I'm joined by Dr. Traci Adams, who I'll introduce to you in just a moment. Before we get started, I want to give just a couple of housekeeping notes for those of you who need some reminders or have not been on the Zoom webinar platform before. If you will, go to your toolbar. It should be at the bottom of your screen. There is a Q&A button there. You can use that for a couple of things. One is if you have questions you would like for us to answer, you can submit those through the Q&A all throughout the program today, and we will try to answer as many questions as we can at the end of our session. You can also go there if you need to let us know about a technical issue or concern, and we do have team members that will try to help you troubleshoot any of those. Additionally, if you will go to the right on your toolbar, you can see an option for closed captioning. If that is something that would be helpful for you, you can go ahead and turn that on and it will caption for you during the session today. I would like to remind you all that this is an educational session for your information and not for personal medical advice. So if you do have questions about your own medical care, please refer those to your personal physician. And finally, I'll ask that if you can, please stay with us at the end of the session. Once we finish the webinar, we will have an opportunity to give feedback. We'd love to hear from you about our session today, about our webinar series, and ideas you might have for the future. So without any further ado, I will introduce Dr. Traci Adams. She graduated from the Baylor College of Medicine in Houston, Texas. She completed her residency in internal medicine at the Massachusetts General Hospital, and then she went on to Pulmonary and Critical Care Fellowship at UT Southwestern, where she then joined the faculty in 2018. Dr. Adams is the director of the Interstitial Lung Disease Program at UT Southwestern, which is part of the Pulmonary Fibrosis Foundation's Care Center network. She has been a great collaborator for us. She's written a mold-related hypersensitivity pneumonitis fact sheet that you can find on the PFF website. And she's also authored papers on the use of bronchoscopy to diagnose hypersensitivity pneumonitis and a retrospective cohort analysis on patients with mold-related HP. Welcome, Traci. Dr. Adams, thank you so much for being here, and I'm excited to hear from you today.
Thank you so much, Amy, for the introduction. I'm so excited to be here. Thanks for joining us for the PFF webinar on mold-related hypersensitivity pneumonitis. Again, as a medical disclaimer, just to echo Dr. Case's statement, please note that any information contained in the presentation is for informational and educational purposes only. It's not intended to be a substitute for professional medical advice, so always consult your personal healthcare provider with any questions you have about your specific treatment. My objectives for the talk today are to, one, help you understand the definition of hypersensitivity pneumonitis. Two, to inform you about the diagnostic workup that patients undergo who are being evaluated for this condition. Three is to discuss pharmacologic treatment options that we have for mold-related HP. And then four, to help you understand the process of mold remediation, which is an important part of the treatment of mold-related HP. So to start, we'll review what is hypersensitivity pneumonitis and why is it important. So remember that interstitial lung disease or pulmonary fibrosis, I'll use them interchangeably through the talk, is an umbrella term. It doesn't tell you the specific cause. For that, you have to get a specific diagnosis. So for some people, their pulmonary fibrosis is caused by autoimmune diseases like rheumatoid arthritis or scleroderma. For other people, it's occupational exposures like asbestos. Hypersensitivity pneumonitis, or HP, is just a cause of interstitial lung disease. And it results from exposure to certain inhaled antigens, things that are inflammatory to the lung. The most common causes of that are going to be mold or avian antigens, so birds or feathers. So if you have ILD caused by mold or bird antigen, that is hypersensitivity pneumonitis. So it's important to move from that umbrella term that you have pulmonary fibrosis or you have ILD to a specific diagnosis of HP for a few reasons. The first of those is that the prognosis in HP is better than that of IPF. I know for many of you, it's important to understand what your life expectancy is going to be, how you're going to do with this condition. What do the next few years look like for you? I get that question in clinic all the time, and getting a diagnosis isn't a perfect predictor of how you will do, but it is helpful as we think about your care and how things will go over the next few years. The second reason that getting a diagnosis of HP is important is that it impacts our treatment options. So idiopathic pulmonary fibrosis, or IPF, really the treatment options that we have are antifibrotic drugs, so nintedanib or pirfenidone. With HP, we can use nintedanib, but we can also use immunosuppressive drugs, things that lower inflammation levels in the lungs, like mycophenolate or azathioprine. And so it's important to know if you have HP, so we know whether mycophenolate or azathioprine is a treatment option for you. And then the last reason that we want to know if it's HP, and I'll talk a lot about this later on in the talk, is that it has implications for what we do with that antigen. So you can imagine that if you have a lung disease that's caused by having a bird in your home or having mold in your home, it's important to remove that exposure, moving the bird to a different home or remediating the mold damage in the home. Both of those processes can be hard. It's hard to get rid of mold in the home. And so we want to know that it's going to help, or that that is the cause of the condition before you undergo a big or expensive mold remediation. So how do we diagnose this? How do I know if mold-related HP is the correct diagnosis for my patient? So we walk through a few things. I'll give an overview here, and then I'll walk through that on the next few. I'll walk through each of these on the next few slides. The first way, and the best predictor that we have to know whether it's HP or hypersensitivity pneumonitis, is the patient exposed to something that causes hypersensitivity pneumonitis? Do they have a bird? Do they have mold in their home? These are really important things to figure out. And we'll talk about how you can work with your care team to provide that information. And we look at how do they do when they get rid of that exposure. If they get out of the house for a few weeks and go on vacation, do their breathing tests get better? Does their lung function actually improve? Because if it does, there's a good chance that it was the home. The next thing we look at is the high-resolution CT scan. This is just a cornerstone of the workup of anybody with interstitial lung disease. And while HP can look like just about anything on a CT scan, can have a number of different appearances. Sort of the most important, there are certain classic features that we see with HP that can help us to determine that that's the diagnosis. And then finally, sometimes we'll do a biopsy procedure, either a bronchoscopy or a surgical lung biopsy, if we need to, and that can help us confirm that diagnosis. So walking through each of these, this is an old study, but I love it. It's from 2003, and it looked at patients with interstitial lung disease. What was the most predictive single factor that led to a diagnosis of HP? And exposure to an antigen that causes HP, remember that's bird or mold, was the single most predictive element of their history in terms of predicting a diagnosis. It increased the odds of having HP by 38 times compared to people without an antigen. So it is a really important part of the history. And we're going to talk about how you can team up with your healthcare professional. I'm limited by, I can ask as many questions as I want. but you can help your healthcare professional figure out what has caused your ILD by just getting a sense of what causes mold in the home and how you can identify it. So when you see an ILD provider, we're going to spend a lot of time asking you about potential HP exposures. Again, there are other ones, but the most common is going to be bird or mold exposure. And for the purposes of this talk, I'm going to focus on questions related to mold exposure in the home. The reason it's helpful for you to know what questions we're going to ask is so that you can be prepared for the visit, because it's hard if you go to the doctor and you think you're there to talk about your lung disease and then they're talking about the foundation of your house. So these are things that you can prepare in advance. The first question that I always ask is just getting a general sense of their home environment. Do you live in a house, apartment, condo? How long have you lived there? How old is the building? The age of the building can be helpful. Obviously, new construction would be lower risk for having mold than a 100-year-old home. And then how long you've lived there is really important. The disease starts when you're in the exposure. So if you have a house now that has mold, but your ILD actually started 10 years ago when you were not in that home and you were not exposed to mold, it's probably, it really can't be the current mold that you have. So it's important to know when the disease started and the timing of that relative to how long they've been in the home. On the figure on the right, you'll see this is a figure produced by the Minnesota Department of Health that just shows different places in the home that you can have mold. So we'll explore each of these with different questions. The first one, the number 5 on the figure, is we ask about the foundation of the home. Homes are typically going to be concrete slab or pier and beam foundation. For concrete slab, if you get a leak under the house, it's generally going to go under the slab. And then if it's really severe, it'll come up through the floorboards and you'll notice. But a pier and beam foundation, where they have a crawl space, you can go under the home. Sometimes if there's not good drainage or if a pipe has leaked, you'll have standing water or mold under the house. So when the air conditioning sucks up air into the unit, they may get mold that's under the house. And so if you do have a pier and beam foundation, we just encourage you to take a look or have a friend or family member or even a contractor look under the house. It does not have to be the world's greatest crawl space inspection. We just want to know if it's dry or is it wet, because mold follows water damage. And you're going to hear me say that over and over again in this talk. The reason that we ask about water sources in the home is that mold grows where there's water. And so knowing whether there's water underneath the foundation of your home is important for those with a pier and beam foundation. The next thing we ask about is prior water damage or flooding. Remember, mold follows water. So I want to know about leaks or pipe bursts or floods. And when you have water damage to the home, so when we looked at people with a diagnosis of mold-related HP that we published in our center, most of the water damage was recurring or chronic. It was a leak that someone had had for years, in the washing machine that leaked behind the wall that they don't know how long had been going on. It wasn't normally a single flooding episode, a single pipe burst. Generally, these are chronic and recurring leaks. But it's important to know that if you have water that gets into porous material, so drywall, carpet, subflooring, sometimes hardwood, sofa material, if that water stays there, if the material is wet for about 3 days, you can start having mold growth there. So if you have a leak, you have a pipe burst all of a sudden, and you know it's a new issue, and a contractor can come in and completely dry the floors with enormous fans, and you're able to successfully dry everything within 2 to 3 days, you should be okay. However, if the water damage lasts longer than that, say your area is affected by a flood or hurricane and you just can't get someone out to the house right away, and that water sits there, it'll leak into the porous material, and then mold will grow, and the fans aren't going to fix that. Bleach is not going to fix that. You really need to have a complete professional remediation, and we'll talk about that at the end. So it's helpful for you when you go see your healthcare provider just to have an idea, start thinking about any prior water damage, because I think we get the best answers and can best partner with patients if you're not caught off guard by a set of questions about your house when you came to talk about your lungs. The last thing we want to know about is any obvious mold growth. People are really good at identifying mold. You don't need a test for it. You can look at it. You know what mold looks like. So we want to know about mold growth or maybe a musty odor when you go down into the basement or something along those lines. The other important thing we focus on to get a good mold exposure in the home is the type of air conditioning unit that you have. So I'm in Texas, pretty much everybody has central air conditioning units. And so we want to know whether there's mold in the vents, because sometimes the AC unit will develop mold in it, sprays it throughout the house, and it's most visible on the vents. For folks with window units, we'd like to know if it drips inside or outside. They should drip outside. If it's dripping inside, that's installed very improperly. And we also want to know if you have a good seal around the window unit. Some people with window units don't seal very well, and so when the rain, hits the house, they will get rained on inside the home. Again, standing water, recurrent water damage leads to mold growth. And so we want to know about window units. And then the last thing we want to know about is swamp coolers. So if you have a swamp cooler, which is pictured here on the right, the swamp cooler is a machine that will suck in hot and dry air and then takes it over a water tank with an evaporative pad on the top that then moistens the air, which a fan blows out. And so it's very likely to have extremely humid conditions, very wet conditions, good conditions for mold growth if you have a swamp cooler. And then we also want to know if the swamp cooler's water has emptied regularly, because standing water that you leave in your home all the time may lead to mold growth. And then finally, we'd like to know about humidifier use. If you do use a humidifier that puts moisture into the air, that's okay. We use that, I use that for my kids when they're sick, and that's okay. You want to, though, empty that humidifier in the morning, every morning, rather than letting standing water accumulate in it and refilling that standing water. Standing water leads to mold growth. So the safest way to use a humidifier would be to run it at night and then dump any residual water out in the morning and allow it to dry completely before you refill it. So that's the antigen exposure piece. Again, really important and the single most predictive factor for a diagnosis of HP. The other thing that I look at to make the diagnosis is the CT scan. So again, a CT and HP can look like all kinds of things. However, it is really helpful if they have this sign. So if you see both inflammation and signs of airway disease like air trapping or central lobular nodules, that can be helpful for diagnosis. So this is what I mean by that. On the CT labeled C, you will see that there are some areas that look very hazy. A good example of this is here with the blue arrow. This is darker than it should be. That's a sign of inflammation. You can also see areas of normal lung, that's over here with the yellow area. And then you see areas that look pretty dark. They look black. That's indicated by the red arrows. Then when you have the patient breathe out, so we get expiratory cuts on the CT scan, the entire scan should turn gray because the black is air and you're breathing out. So you shouldn't have black, you should have gray. But this patient still has black. And you can see that in the areas where the red circles have been. That's an indicator that there may be airway disease, which can be caused by lots of things, but HP is one of them. Remember, it's a disease from inhaled antigens, which go through your airways. So it's not surprising that someone would have airway disease. If your scan looks like this and you have mold in your home, we can make a pretty reasonably confident diagnosis of HP, actually without even pursuing any further workup. If your scan doesn't look perfect or we're not so sure about your exposure, we may need to do a biopsy to confirm the diagnosis. You can do that with a surgical lung biopsy. That's the big procedure where they take a large sample of the lung and look at it under a microscope. There are risks to this procedure, which is why we try not to do it. And what you'll see is a lot of inflammation. So the inflammation are these kind of dark purple circles. Those are lymphocytes, because this is generally an inflammatory interstitial lung disease, as opposed to IPF, where you really shouldn't see these. And then what the arrows are pointing at, and what, the slide D kind of magnifies, are features called granulomas. HP is not the only thing that can produce granulomas, but if somebody has a bird or home mold exposure and you get this biopsy, that's excellent for a diagnosis of HP. So the big surgical lung biopsies are great in that they provide nice big samples, and we can get a diagnosis more than 90% of the time. However, it carries with it a pretty high risk of morbidity and mortality. It's a significant procedure to undergo. So I've spent a lot of my research time, my career, trying to figure out minimally invasive ways that we can diagnose HP. So a procedure that we've been doing forever is bronchoscopy, where they put a camera down into the lung, take washings, and take samples while we're there. And we found that in patients who were ultimately diagnosed with HP, bronchoscopy, particularly when we combined the lavage with the transbronchial biopsy, was diagnostic in about 50% of individuals, meaning we're able to avoid the big surgical lung biopsies in about half of individuals with HP. And so the hope is that by getting a good exposure history that you partner with your doctor, we may be able to just confirm the diagnosis either with the CT or with a bronchoscopy, which is a much lower risk of complications than a surgical lung biopsy. So moving on, once we have the diagnosis of HP, the next step is that we want to treat. So remember that HP can be treated by both immunosuppressant drugs and antifibrotic. So I'll start with the immunosuppressant drugs. This was a study that was done by Julie Morissette, where they looked at patients with hypersensitivity pneumonitis. And you can see the curve, this black line. Patients were getting somewhat worse slowly before treatment. So they show how they did in terms of their breathing tests for 24 months prior to the study. Then they looked at how they did afterward. And so the black line after time 0 represents how patients did on therapy, either mycophenolate or azathioprine, compared to how they should have done if that kind of pre-treatment trajectory was projected forward for another 18 to 24 months. And it turns out that there's a difference between these two curves, meaning people on immunosuppressants did better than people who were not in terms of FVC, which is forced vital capacity. That's a breathing test that we measure. And so that's what led to, us using azathioprine and mycophenolate as first-line therapy in folks with HP. The next group of drugs that we can use are antifibrotics, and the antifibrotic option we have for HP is nintedanib. So this data comes from the InBuild study that was published in 2019. In this study, it was a randomized controlled trial, unlike the last study we looked at, which was just retrospective. In this randomized study, they took patients, some of you may have even been enrolled in this, who had gotten worse by a set of breathing tests, CT scan, or symptoms over the last 2 years. And then they randomized them to being on nintedanib or placebo. And what you can see from the chart is that people who were on placebo, so that's the light blue line there at the bottom, they continued to have a decline in their FVC. And they lost about 200 cc's over that first year. Patients who are on nintedanib did decline over that year, but they did much better. Their decline, the amount that they declined was much less than folks in the placebo group. And so on the basis of this study, when we see someone with this took all comers with a diagnosis of fibrotic interstitial lung disease that got worse. but patients with HP were included in this study. So on this basis, we can now use nintedanib for patients with fibrotic hypersensitivity pneumonitis that gets worse over a 2-year span. We can add nintedanib, and the suggestion of this paper is that they will decline less rapidly than they would if they were just on placebo. There is a new clinical trial that has come out. This drug is not yet approved by the FDA. We do not know whether it will get approved. Your providers cannot yet prescribe this drug. We don't even know if it will get approved. But this was a study that was published about a month ago in the New England Journal of a drug called nerandomilast. In this study, they took patients, just like in the InBuild study that I mentioned on the last slide, who were getting worse over a 2-year period. And they randomized them to the study drug, the nerandomilast, or placebo. Again, in this study, they found that people in the placebo group, so if they didn't get anything, they did worse over that next year. In contrast, in patients in the study drug group, in the nerandomilast group, regardless of the dose used, they actually had a tiny bump in their lung function very early on after initiation of the drug. And then they did get worse over time, but after a year, they do better than people who were not on the drug. Once again, this data has been submitted to the FDA, and we do not know if or when it will be approved, but it does look promising in terms of another antifibrotic option that we may have in the treatment of hypersensitivity pneumonitis. So the last thing I'll talk about is we're talking about mold-related hypersensitivity pneumonitis, specifically mold in the home. So why do we need to get that mold out of the home, and how do we do it? So the reason that we need to get mold out of the home is that it's an intuitive approach, which is that if mold is causing the disease, it makes sense that you should probably not breathe that in anymore. But we have data as well to support this. So this was a study that we did here at UT Southwestern, where we looked at our patients with a diagnosis of hypersensitivity pneumonitis from any cause, birds, mold, other. And we took we looked at their lung function and their survival over time. What we found is that the blue line is folks who we knew what their HP exposure was. So they told me, I have a bird or I have mold in my house. And they got rid of that by finding the bird another home or remediating the mold in the home. The red line here is people who identified the antigen, but they maybe weren't able to move out of the home with mold, or they chose not to get rid of the bird. The green line is people that we know had a diagnosis of HP based on their CT and their biopsy results, but I could not find an exposure. They looked in their home, I asked them a million questions, and we couldn't figure this out. What we see here, so this is a survival curve. So the blue curve, people died less fast if we identified and got rid of the exposure. In other words, survival was better for getting rid of exposure, which is a pretty good reason to get rid of exposure. Patients in our center lived longer when they did, compared to people who chose not to get rid of the exposure, or who I couldn't identify the exposure. And presumably those people weren't able to get rid of it because they didn't even know what it was. So finding the exposure, partnering with your healthcare team to find it and then remove it can help. The other thing we found in our study is we took people and we said, hey, if you remove the exposure, how do their lung function tests do a few months later? And what we found was that for patients who had more inflammation and no fibrosis on their scan, almost 60% of them had an improvement in their lung function by about 10% just with exposure removal. This is not starting drug. This is no medicine, just getting out of the exposure. So just remediating the home mold, they got better. For folks who are more fibrotic, so the more scar they have in the lung, that tends not to be reversible. And so for patients who are really fibrotic, we didn't see an improvement. But the hope is still that they, at a minimum, are able to stabilize and do better than those who choose not to remove the exposure. So when you're thinking about taking on a mold remediation, if your physician diagnoses home mold-related HP on the basis of your exposure, plus your CT scan, plus or minus a bronchoscopy or surgical lung biopsy, the first step you want to take is to identify and stop the water intrusion. So how do you know where it is? Well, if you identify mold, for example, in the ceiling, you're going to want to look in the attic, or if any plumbing is above that. For example, if the leak is on the ceiling directly below the second floor bathroom, that would be a good place to look to check those pipes. You can have a mold inspection company come out if you would like, and they can do air quality testing where they sample areas inside the home and outside the home, and they can help you come up with a mold remediation plan. But if you know where the water damage is coming from, you know that it's a sink that's leaking or a water heater that's leaking or a basement that is recurrently flooding, the most important first step is to stop the water intrusion. Remember, mold follows water. So if you do this whole remediation and it just floods again, that's really not going to solve the problem. So you have to stop the leak, get a plumber out, or figure out a drainage solution for the home if it's a flooding one. The second step, once you've stopped the water damage from recurring, now we have to cut out those porous materials, the drywall, carpet, subflooring that was affected by mold exposure. So if you have, for example, a flood coming in, let's say your home recurrently floods because the land is sloped such that every time it rains, water runs into your house. Well, you can solve that problem by putting in a French drain, but now you've gotten water damage to the bottom of your drywall or in your carpet from where the water has entered your home. That has to be removed if it's been wet for more than 72 hours. And so if it's a recurring problem, likely it's gotten wet and you need to remove it. Remove all the porous materials, cut it out, leave a nice margin where you know that that carpet or that drywall was not affected. Once you've confirmed that all of the damaged area has been removed, and you've identified and stopped the water intrusion, now you can move on with repair. So installing new drywall or new carpet or subflooring to replace the holes in the walls that you've made during the mold remediation. It's important to note that all of this can be done by contractors. You should not, if you have mold-related HP, be the one doing the work yourself. Because when you remediate mold, you can get a big mold exposure as you're cutting out that drywall that's been impacted. So you want to make sure that you're not home and specifically that you are not the one doing the work. So a couple of mold remediation pearls. If you think you see mold and you realize that it's in an area of water damage. So again, where water isn't intruding into your home, or you have a leak, you see black mold, you know what it is. You don't need to have a mold inspection company come out and swab it. If it looks like mold and there's a compatible water leak, that's what it is. We don't need to do a few $100s worth of testing to confirm that. But if mold is suspected, but it's not visible, so for example, you've had water damage there, someone's painted over the wall, you don't really know if there's mold behind the wall, or you have a shower leak and you don't know if mold is behind that, you can have a mold inspection company come out and test. And mold is present in ambient air at really at low concentration. So if they test your indoor air, they'll see mold there. But it's important to test both indoor and outdoor concentrations of mold. If the mold concentration is the same indoor and outdoor, you don't have a problem. Where there's a problem is if you're seeing a big increase in the amount of mold in indoor air relative to outdoor air, because that lets us know that there is a mold growth problem in your home. Mold inspection companies can also drill behind walls, take a look at things, and give you a sense of where the issue is. And they can come up with a remediation plan. They'll then give that remediation plan to you, and you'll send that to a mold remediation contractor who can come in and do the repair work. Remember, please do not do this repair yourself, and don't be in the home when they're doing the repair. Once the repair is done, you then hire another party to come back in and do the work to restore your home. But if you know that it's mold, you know that there's a leak, you can likely do this with a series of subcontractors where you have a plumber address the water issue, and then a contractor come in and remove the mold. You'll want to work with someone who's certified in mold remediation, and then someone else come in and do the reinstallation. And it's not something that you necessarily need to test, although there are mold inspection companies who will do that for you if you're not sure. Just remember that they need to test if they're going to do air quality samples indoor and outdoor, and it's the difference that matters, not the absolute amount. And so I'll just conclude with this. Mold-related HP is a very treatable condition. We want to diagnose it because it informs prognosis and our treatment options, and helps you to decide whether remediating mold in your home is a time and expense that you want to go through, because it is hard and it can last several months of a home renovation project, which can be very stressful. We make that diagnosis with a history, a CT scan, and sometimes a bronchoscopy or even a surgical lung biopsy. We have medication options. We can use both immunosuppressants and antifibrotics to treat this condition. But we know that ultimately patients will do better, their survival is better, and their lung function could improve if they're able to remediate that exposure. And so mold follows water damage. So to remediate an exposure, you start with fixing the water, then you fix the drywall, and then you go back in and restore everything. And let your healthcare provider know when you've done that, so that you can see if there's any improvement in your lung function. Even if there isn't, in many cases, we don't see an improvement, the goal is stability. And you can achieve that and partner with your healthcare team to achieve that by remediating the mold damage. I really appreciate your time, and I'm happy to take any questions that you have.
That was a wonderful presentation. Thank you so much. And we do have a good amount of time for questions, and a lot of really thoughtful questions that people have submitted. So if it's okay with you, Dr. Adams, I'm just going to dive straight in. One question that I actually have as well, but this was submitted, was really getting at the dose and duration of exposure. There were several people that mentioned a long latency period, maybe, known exposure, but something when they were much younger, growing up, a young adult, and now their pulmonary fibrosis is diagnosed much later in life. And can those two things be, are those two things related? What is
right, dose response? Yeah, that's an excellent question. So the disease has to start when you're in the exposure. And so if it was your childhood home, you moved out of that home at 18 years old, and then you were diagnosed with pulmonary fibrosis in your 70s, it is not the childhood home. Those are too far apart. However, let's say it was an apartment that you lived in 3 years ago. You started coughing when you lived in that apartment, you moved somewhere new. There's no active disease in the apartment, but you find out that that cough was actually pulmonary fibrosis. You don't have to still be in the exposure to get diagnosed. It's really when symptoms start. In terms of the latency period, so this is a really interesting issue. It can happen at any time. So there are people who can get an acute onset HP if, for example, they cut down a tree that has a ton of mold growing on it. They get a big exposure and they get sick right away. For other people, they can live with the mold exposure or having a bird for years or decades before they develop the disease. So just because you've had mold in your home for 20 years and you just got diagnosed with pulmonary fibrosis, that does not exclude the mold as a potential cause. It doesn't have to be when you first move in. It really can be at any time. And we think that has to do with the immunologic nature of the disease, but no one's really answered that question. In terms of the dose of mold, this is where it gets really tricky. We know that visible chronic mold damage that is in a room that you go in frequently or in an air conditioning unit is enough to cause HP because it's an immunologic mechanism. So it doesn't take a lot. It's not necessarily about cumulative exposure. It's about your body's reaction to it. Most people are going to have mold in the grout in their shower or something along those lines, maybe a little rim around the sink. That's not the kind of mold damage that we're worried about. I'm worried about mold in the drywall, mold that's more extensive than that. But to actively, actually perfectly quantify it, we can't do that. I will say in our, because we don't know the exact threshold, but in our HP paper, when we looked at everybody at UT Southwestern with home mold related HP, these were visible extensive mold damage due to a chronic or recurring water source. It wasn't generally a one-off small flood. People who got HP had a lot of mold.
That's very helpful. I'm actually going to ask a couple of other similar questions about dose and exposure because there's some that I think come up frequently. I end up talking about them frequently in clinic, and so I think people are thinking about these things, particularly as we have long lives and we are exposed to a lot of things, and so I think as we're going back and wondering, these things do come to mind, and we're not sure how to deal with them. Another question that has come up is, you've talked a lot about home exposure, but what about more intermittent types of exposure? Let's say with an occupation, maybe I'm going into various homes for whatever reason, or various environments that have this one may have water damage, and also this one, or an occupational exposure that you're not living in, but there it is.
Yeah, so once again, that exact dose, exactly how often you have to be in a building with mold to get HP, I can't give you, I wish I could, a cutoff, and there are people who fall into this gray area. If you're working a normal 8 to 5 office job and there is mold in that office, that is plenty of exposure for you to develop HP. Or if you work in, let's say, a facility that does fruit and vegetable cleaning, a lot of fluid, very high humidity environment, you got a lot of water in there, everything is wet, that is plenty of exposure to potentially develop HP. Or let's say you do construction demolition, and sometimes you might be doing some demos of some areas with mold, but most of the time you're not. And so you maybe only enter a mold related home a few days a year. That's probably not enough. But there are people who fall into this gray area, and where I wish that we could take an exposure history and have a solid yes or no every time. Dr. Hajari case and everybody doing pulmonary fibrosis knows there are people who just fall into that gray area. And that's where some things like a precipitin panel can be helpful, but that's often why we end up getting tissue when I just don't know that the exposure was often enough. Or let's say it's a lake house that you go to one weekend a month, sorry, is that enough? Probably not, but if you're going there every weekend, I think it is. So, and I've certainly seen that, and we saw that in our series as well. Those weren't included, but in our retrospective different studies, we've seen that. So I think it's got to be pretty regular, but where exactly you draw the line, what exactly is regular is not known.
Absolutely. Those gray areas are so hard, both for everybody involved. Another question, this has come up a couple of times as well, is the outdoor environment. A lot of gardeners, people who enjoy being in, outdoor spaces. Certainly molds are ubiquitous in our environment. You just
Right.
mentioned that the comparison between the indoor and outdoor air is important when we're assessing the environment. Talk about people whose perhaps outdoor hobbies might have them exposed maybe more in a concentrated way. Do you consider that a risk factor and something that people need to meet?
Yeah, good question. So, just being an outdoor enthusiast, if you love to hike, camp, just be outside, that is not considered an exposure. The concentrations of mold in ambient air are not high enough to cause HP just from being outside. So that is a good thing. But there are some hobbies that can increase your risk for mold exposure, and some of those are outdoor. So if you love working in your garden, that's great, and that's not going to give you HP. But if you have a compost heap, so you're making your own fertilizer, that is basically allowing materials to compost where mold and different bacteria grow to change that from waste to, compost that you can use to fertilize your plants. And that exposure, especially if you're out there a lot, you're churning the compost a lot, you're using it a lot, that's a big mold exposure. The other hobbies we ask about are pools and hot tubs. Hot tub exposure, not exactly mold, it's thought to be a mycobacterial, but same idea is that it can give you, it's those high concentrations, it's in the water, and then high humidity coming off the water is a great environment for bacterial and mold growth and can cause HP. How often do you exactly need to be in your hot tub to cause mold, to cause HP? No one can tell you the exact cutoff. If it's once a month, probably not. If it's a couple times a week, now we're talking. Sauna use, particularly, so not so much the dry saunas, but the wet saunas, that's a very high humidity environment. So if you're doing that a lot, that can cause HP. Pools, outdoor pools are not so bad, but indoor pools, the natatoriums are extremely humid because the air is just equalizing with the water. It's a really humid environment. So if you work as a lifeguard in an indoor pool, you're swimming in an indoor pool often, that can cause HP. Other hobbies that we look at are actually wind instruments. So you can get some like a bagpipe or lung, and it's really because the mouthpiece can get spit on it and over time can grow mold because mold follows water. And so you want to make sure you're mindful of those mouthpieces of instruments. I've asked, I don't know, thousands of ILD patients about musical instruments. I've never once found a musical instrument related HP case, but they're out there. And then we ask about metalworking and woodworking. With metalworking, we want to know about any metalworking fluids that you're using. So for people who do a job that involves cutting metal, working in a factory, that you can get HP from some of the metalworking fluids that are in that environment. There are other diseases types of ILD that can be related to metal cutting. So we may kind of drill down on that if that's something that is apparent in your history. The other thing we ask about is woodwork. So remember, mold follows water. So if you're using a really porous wood like cork, or if you're going down, chopping down lumber that's, out in the open, so these trees have mold on them, and then processing that wood, that can cause mold. Or if you're leaving your sawdust out to get wet for days, or your wood to get wet for days, and mold grows in it, and then you cut it, and you're doing that on a regular basis, that can cause HP. Purely being outside, not going to do it. Being outside and working with mold, so compost, wood that's allowed to get wet, doing regular tree removal of trees that have mold on them can lead to an exposure that can cause HP.
That's all such great information. Thank you. There were several questions about the slides and recording, and I want to just go ahead and address that before we get to the very end of our questions. So I do have other questions for you, but if you will, audience, navigate to the chat function. Our PFF Help Center has uploaded Dr. Adams' slides in PDF form, and you can go there and download them for future reference. Additionally, we are recording this session and it will be posted to our website probably in the next couple of weeks once it's been finished off and posted. So for those of you who asked about that, thank you for those questions. And hopefully you're able to download the slides or review this later if you're interested. Dr. Adams, I'm gonna switch gears just a little bit, actually kind of a lot. And because there is just as much interest in detection and mitigation as there is in the amount of exposure, and I think this can be really hard for people when you tell them that they've got to, mitigate in the home, look for, search, and it can be really overwhelming when you go to look for somebody to do that assessment in your home if nothing's visible necessarily, or to figure out who it is that needs to come in and mitigate in the home. So talk first about what, I know you mentioned this, but I want to just make sure everybody's heard it, but also how would you go about finding someone, a company, an individual, a business to come in and test inside the home and know whether they are legitimate in doing so?
So a certified industrial hygienist is going to have a certification that allows them to test. I would imagine that if you're seen at a pulmonary fibrosis center of excellence, they would know industrial hygienists in the community that can come out to your home. Now, if you drive a really long way to the PFF site, so we have patients who are in different states that come in to see us, I may not know what is local for them, but there is an association of industrial hygienists, maybe I'm blanking on the name of their organization, that would be a really valid way to double check that they are certified to do mold inspections.
That's very helpful information. As I'm sure you know, there are lots of folks who would want to come in and start swabbing things around your house and charge.
That's right. Don't let them swab. If it looks like mold, that's what it is. And actually, our paper was really designed to be kind of just a common sense approach. The vast majority of people in our study didn't have a mold inspection. They just saw it. It's normally not that subtle. And if you can think back to where you may, like, my intent of this talk is not to make everyone nervous that they have some mold damage in their house, although that may have been an unintended effect, and I apologize. What I want you to just think of is, have you had water damage, leaks, pipe bursts, floods? Or are there any areas where you've noticed mold or something, a room kind of has a musty smell to it? And if there is, it's worth looking into to ensure that there's not mold there. But if there's not, it's probably not HP. It could be, sometimes you just can't find it, but it's probably not HP if there's nothing obvious. Again, the vast majority of our patients in our home mold case series, the patient told us that. We didn't have them go get an industrial hygienist because we recognize that in some rural communities, that's simply not possible. And what we found is that most people with mold-related HP are able to get it on their own, catch that on their own without bringing in outside help, which can be fairly expensive.
Absolutely. Talk a little bit about mitigation and your advice that you give to your renters, for example. I know this can be really challenging. Not everybody can pick up and move at the drop of a hat.
Right.
It's very hard. And what I'd love to hear personally, and I'm sure our audience would like to hear as well, what advice you can give to those who may have a hard time moving and may not be in a position to authorize a mitigation themselves.
Right. I empathize for you in that situation, man. It's hard. Not everybody can move or do a huge remediation. I will say that we have medicines that can treat HP, and so I want you to be assured that you're not just going to keep going back to the doctor and there's nothing they can do. There are things that we can do outside of the remediation. What I'll often do for patients who, for example, need to be able to break their lease of the apartment, they can switch apartments, but not for another, however long their lease is I'll write a letter of medical necessity, saying that they have the disease, that it's caused by mold exposure, that mold exposure is in the apartment, and is medically necessary that they get out. It doesn't always work, in Texas, the laws are not really favorable to renters, maybe different in different parts of the country, but there are things we can do in terms of treatment, and you just want to do the best that you can. I wish it was that easy for everybody, and it's just not. But HP tends to be a disease that progresses more slowly than IPF. So even if you can't move out tomorrow, if you can do it in a year or 2 years, just kind of making that plan, I think is a helpful step in that direction.
That's great advice. Thank you. We are almost out of time, and I did want to just mention the organization again, you said American Industrial Hygiene Association, is that right?
Yeah, I need to look back because they have a fairly long acronym and I can never remember it. I'll look and send it out to you, and you can send out to the folks registered for the webinar. But they do have a certification that individuals go through to do mold inspections. They're industrial hygienists, and they have an association. And they can be that can be a way that you can verify that the mold inspector you hire is in fact qualified to do that.
Fantastic. This has been such great information, and I wish we had more time to go on and answer more questions, but we are out of time for the day. I did want to just remind everyone, if you had not had a chance in the last minute we have here, to download the slides there in the chat function there, and you can grab those. We will post this recording later. I'd like to thank our sponsors of our webinar series today, and ask you to stay and give us some feedback if you have a moment. Finally, I want to just let everyone know that we do have our next webinar coming up on July 23rd. We will be talking about pulmonary hypertension related to pulmonary fibrosis and interstitial lung disease, so it should be a really exciting topic and very interesting, hopefully to everyone. So please get registered when you see that link come up, and we'll see you then. Dr. Adams, thank you so much for being here. This has just been great information, and I know our community has benefited from it. Have a great day, everyone.
Thank you.